Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
Good morning. How is it going? Happy Tuesday. Hope you guys are doing fantastic. I guarantee you I am. Ready to tackle a phenomenal AEP this year. As we're closing in, we are down to the last week, man. 7 more days and it's go time. Absolutely. Got some interesting stuff lined up for you guys today, man. There's definitely some news, a few items, and we're going to talk a lot about the cost of Medicare as it's projected to go up. We're going to look at some of the projected numbers for 2026, and we're going to look at some projections all the way to like 2034 on what the cost of Medicare looks like. So if you are looking to get your head wrapped around what the future of Medicare may look like a little closer, at least in regards to cost, stay tuned because Kiplinger put out some really solid info regarding the cost of Medicare and what it's going to look like over the next several years. Which, I mean, unless you're living under a rock, you should know that the costs are going to be going up. I mean, that's one of the only truths that we have in this world, right? Is that costs go up, right? Death and taxes, as they say. So we're going to jump into that. We're also going to talk a little bit about some skilled nursing stuff, some recent news regarding prior authorizations, technology stuff that CMS is incorporating, and I've even got a little bit of fraud to kick it off. As always, of course, this show is brought to you by DFY CRM, my CRM of choice. And there's a few reasons why I love that CRM. Number one, it's all inclusive. Everything's right in the box. Open it up. It's ready to go for you, man. All your cool automations and everything. But even then, plenty of room to customize what you need for you. And that's something that we're doing over at Avila is we are building some custom workflows, some custom pipelines, custom customer journey that is really going to help our team out greatly. Not only when it comes to just tracking their customers through their journey, but in teeing up the proper cross-market, the proper items that they need to be pitching to these folks and explaining to them and educating them on. So super excited to be rolling that out for Team Avila. Stay tuned because we will possibly make that available to independent agents too, other than the crew here. But let's dive into it, man. I want to dive into some of this. As I mentioned, I got a little bit of fraud to kick it off with, nothing major, but I thought this was pretty interesting. Let me drop this on the screen for you real quick. I mean, let's be honest, like Medicare is definitely ripe with fraud. And here we have a podiatrist and a sales representative admitting to guilt in a Medicare fraud conspiracy. Well, what the hell did these two guys do? It's out in California in Fresno. A U.S. attorney announced that 2 men have pleaded guilty to conspiracy to commit healthcare fraud. According to the court documents, 51-year-old Felipe Ruiz, a podiatrist at West Coast Podiatry, and 52-year-old Jose Gabriel Aguirre, a sales representative, engaged in fraudulent activities involving skin grafts. Basically, between June of 21 and June of 24, or January of 24, Ruiz purchased skin grafts from Aguirre and allowed him, despite not being a licensed healthcare provider, to apply them to Medicare and Medi-Cal beneficiaries. Here, you're a sales rep. Here's some skin. Go ahead. Stitch it on them. The fraudulent scheme involved submitting claims to Medicare and Medi-Cal, falsely stating that Ruiz, the actual doctor, had applied the skin grafts when, in fact, Aguirre, the sales rep, performed the services. Consequently, Medicare and Medi-Cal paid Ruiz for these false claims, and Ruiz then compensated Aguirre. This case is the result of an investigation by the U.S. Department of Health and Human Services, and they are both scheduled to be sentenced by a judge. Could face a maximum 10 years in prison or $250K. That's pretty wild to me that they would just allow a sales representative to go ahead and apply skin grafts. I don't even know what to say about that. But all right, let's get to some real news. Moving along, this just dropped. This is in Healthcare Dive. And you guys may have seen some of this in the very recent CMS final rule, which I'm going to talk about a little bit. It was just basically an update regarding tech stuff. Wasn't a massive final rule that for us, but it was a few items they dropped in the tech space. But basically, and this is probably one of the better ones, hopefully. But Medicare Advantage plans are to share their provider directories under CMS's most recent final rule that was originally proposed back last November, but it comes amid a push for more transparency. So what are they talking about here? Pretty simple. Basically, seniors that are shopping Medicare Advantage plans, they want to give them clearer, right, and more accurate data about payers and provider networks. Now, if you're an agent out there in the Medicare space, whether you're using Connecture or you're using healthcare.gov or Medicare.gov, or maybe now you're using Health Sherpa's Medicare platform or using Sunfire or whatever it might be, or even if you're using the carrier's site to shop for providers, to try to find that primary care physician, that dental provider, whatever it might be, to verify that they're a network for the plans that you want to propose for your customer, you have probably found a ton of inaccuracies. And it's not just in Medicare. Like I had this problem with the dental product that I was working with on someone just recently, helping them out. Like the provider directory on the carrier's website showed this guy not only as in network, but as one of the preferred providers that'll give the discounted or negotiated better rates. Turns out, no, he's not in network at all. He's not in network at all. Not even just that he's in the super PPO version of the network. He is not in network at all. Extremely frustrating for you as an agent because ultimately you end up kind of looking like an ass, right? If you sign someone up with a plan and you tell them, hey, your doctor is going to accept this, or this provider clinic that you like going to is going to accept this, and then they go and then they find out that you're full of shit, and it's not your fault. It's the fact that the provider networks are just not accurate, right? It's a big issue. It's been an issue for a long time. And I don't know where the problem specifically lies and what is preventing a carrier from having accurate provider directories. Doesn't make any sense to me why they wouldn't. I've never seen anybody talk about the why. Like, why are providers having such a problem keeping their provider directories up to date, or why are carriers having such a problem? Is it laziness? Is it just everything is done last minute and getting these contracts signed for these providers that are going to be in network and who's not, and then getting it updated? Is it just a lack of staff? Like, I don't know what the problem is and why they can't do it, but Medicare is saying, hey, you guys need to clean that up, period. So what they are requiring right here, it says regulators are requiring MA plans to directly disclose their provider directories on Medicare Plan Finder for the 2027 open enrollment. So it ain't going to happen this year, but 2027, in a year and a half almost, they will be required to make sure that their provider directories are up to date within at least 30 days of finding out that there's been a change, right? Basically what they say here, pretty simple. I'm just going to scan. Where did it go? So it was originally in a final rule a while back, but then they just updated. And here we go. CMS is requiring that MA plans submit their provider directory data to be published online, update their provider directory information within 30 days of becoming aware of any changes, and attest at least once a year that their provider directory information is accurate. Something else that I noticed they didn't talk about or include, at least in this article, and I didn't see it in the final rule either, at least the summary that I read, is what error rate are they allowing? Like, what is the error rate that they're allowing to say accurate? Are they wanting 100% accuracy, which I would certainly love, but seems kind of like a pipe dream a little bit there. So I'm kind of curious, like, what is the error rate that they're going to allow accuracy to be claimed? But certainly this would be a big thing. I mean, if they're, because not only will it help Medicare.gov Plan Finder, which some of us use, right? Certainly beneficiaries that circumvent the agent and they enroll on their own, they're using that. They need good data, but that theoretically should spill over to all of us that are using alternate platforms like Sunfire, like Connecture, like Health Sherpa, like maybe Ascend, if anybody's actually using that one. And I hope you're not, but maybe you are. But again, the idea is that this is going to promote better choice, better access, and better transparency to the beneficiary to make sure they're picking the right plans, right? Raise your hand if you've had a problem writing a client and then finding out their doctor or their provider's not in network. It happens. We had this happen last year after AEP here in the Austin area. Humana was having a big issue with the Baylor Scott and White provider network. And all of our systems were saying that the Baylor Scott and White doctors and providers were in network for Humana. Well, it turns out they weren't. So we had numerous people that we had to go fix during OEP and get them moved over to either a Baylor Scott and White plan or something that their favorite doctors would accept. So it's frustrating for you as the agent because, and I can imagine how frustrating it is for the client to have to deal with that when they need care and then they're being told that they get to go to this doctor and then it turns out they can't, right? They come back to you, they complain. It's a possibility for you as the agent to receive a complaint to Medicare, which is no fun. And then we got to go back and document that. It's like, hey, man, the provider director, it ain't me. It's the provider directory from the carrier that I'm getting that's being fed to me through Sunfire or Connecture. And I'll say this as a disclaimer. A lot of agents out here complain like, oh, Sunfire's provider directory is bad, right? You can't use Sunfire and trust it. It's not Sunfire. It's not Connecture, and it's not Medicare Plan Finder. It's the directories that the carriers are pushing to those systems, right? Those platforms are just an aggregator of data and then sorts it out. They are not creating the data, right? They're organizing it to make it easily interpretable for you. So it's only as good as the data that the carrier pushes. So if the carrier is pushing inaccurate provider data to those platforms, then you're going to get inaccurate provider data. And again, the problem goes beyond that because it's not just there, but then a lot of times you will go to the carrier site, like in the case I was just talking about, and you'll find out like it's still inaccurate even on the carrier site, right? So when you go through 3 steps as an agent, you check it on Sunfire, Connecture, or whatever, looks like it's working. You check on the Humana site or UHC site, hey, double verification, right? Or sometimes you might get conflicting answers. One says it is, one says it isn't. And then you pick up the phone and you call them and then find out maybe hopefully some data. But that's not the work that we should have to do. We shouldn't have to go to that extreme to have to go 3 layers deep to verify that a provider's in network. It should be very simple for carriers to update their provider directory and push it out with accuracy. So I'm looking forward to that. But again, they're not going to require this until the 2027 AEP, which is a little over a year away. But it should be a good push all in all because it will not only, because it'll speed up accuracy or it'll provide accuracy and speed up and prevent us providing inaccurate information. So, and that came from part of this, came from this final rule right here. This is an article from American Hospital Association, but some of it is listed in here right there. On September 18th, they released a new final rule. There was technical changes to the Medicare Advantage Part D, and the big part about it was the directory data in Plan Finder. They want that shit up to date, and I don't blame them. I would want it up to date too, because again, the big problem is not just in the inaccuracy of it, but it's what happens when that inaccuracy is put into play. Because again, if you're a broker and agent, you should be super concerned because it can certainly result in complaints to Medicare. So if they can clean it up, theoretically, they're going to have fewer complaints to Medicare. They're going to have a more efficient system all around. So over and above, it should be outstanding. And that's not the only thing that they are working on when it comes to tech. There are quite a few tech initiatives that Medicare is working on to give patients and providers better access to health data, as this article from Fierce Healthcare says. So if you cruise through this one a little bit, and I'll make sure definitely this one is in the group. I'm not going to go through the entire thing. I want to point out these major 5 bullets that they are talking about in regards to tech initiatives that they are bringing to Medicare to ultimately improve it. Number one, and this is the one I just talked about, CMS plans to build a national healthcare directory, starting with the provider info. The goal of the National Provider Directory, a source that attended the meeting wrote, is to establish a single source of truth for provider information that others can build upon, right? Fairly simple. And as a matter of fact, they are doing a pilot in Oklahoma on that and using that as a model for the National Directory. Number two, CMS plans to implement a federated modern identity verification solution to Medicare, with leaders pointing to login.gov or Clear as examples. Individuals will verify their identity once and use it across multiple systems, including providers and payers. Now, I thought they were already doing this through the ID.me identity verification platform. It wasn't too long ago that I was helping a turning 65 gentleman enroll in Medicare A and B. And when he and I went through the site, like, it forced him to go through the ID.me verification. Perhaps we clicked a button incorrectly, but I already thought that was kind of part of it, that if you wanted to set up your online account with Medicare or with Social Security, you had to run through that ID.me verification, which I have an ID.me account for some of the different things that I've used. Seems to work great. So I'm a little confused as this is why they're implementing a federated modern identity verification system. I would think they already have one. So maybe there's some gaps in there I've missed, but that is another initiative they're working on. Number three, CMS plans to create a type of digital insurance card for Medicare beneficiaries, allowing for real-time access to coverage information for patients and providers. It will also expand patient access APIs through the blue button and make APIs more usable and scalable. And if you're wondering, like, well, what APIs are they talking about? Well, they're talking about prior authorization APIs. They are talking about certainly provider options, et cetera, real-time claims data, risk analysis data that will all run through that API and into the blue button of some sort. So I'm super interested in that. I'm assuming that digital insurance card would be something that they can have on their telephone, right, where they can pull it right up, get access to everything they need, et cetera, et cetera. Number four, CMS will also take its data at the point of care from a pilot into general availability. The program enables providers to access Medicare claims data for their patients directly within the workflow. This kind of actually ties into number three as one of the APIs, so they can get, again, real-time claims data for their patients. Number five, CMS will fully participate in the trusted data exchange to better respond to patient and provider requests and create a more interoperable and patient-centric system. So the whole goal is to be able to not only create increased transparency, right, through tech initiatives like the provider directory, et cetera, real-time access to claims data, prior authorization. We've already talked about this a couple of times. They're using, they're testing in 6 states an AI model for prior authorization across a subset of specific procedures. There's about 17 specific procedures that they put on that. Ohio, Texas, was it Florida, Ohio, Texas? I think there's a handful of states. I can't remember right now. I've put it in the group. You guys have certainly seen that. So these are some similar type initiatives that they're putting forward to really bring in more tech to create a more efficient system, a more transparent system, which should not only make sure that we're finding the right providers, but we're finding the right data and we're able to get these clients in the right plans, but also make sure the providers are able to help them at a much more efficient rate and prevent a lot of delayed care is a big part of it. Moving along, and I already mentioned this, but we'll jump on it again anyway, right? AI will soon weigh in on whether some Ohio Medicare recipients need certain medical procedures, right? So I've talked about this. I just hit it on the nose, but this is that new pilot program where they are going to use, I believe it's in 6 states. They're going to use AI for certain prior authorization procedures, certain skin replacements, a lot of nerve stimulation, like vagus nerve stimulation. That was a big part of it. So all of those things will have prior authorization, which they already do, but they're going to specifically run those on AI in an effort to increase efficiency and reduce fraud, waste, and abuse. So this is just another article that's talking about it, how it works, right? this one's specific to Ohio, but again, they're doing this in 6 different states. So I'll throw this one in the group if you guys want to dive into a little bit more, but I think that information has pretty much been exhausted at this point. Next up, and this one's interesting, but I'm not really sure how they're going to do this. It sounds great, but CVS, right, which is Aetna Health, right? CVS owns the Aetna products. CVS to expand a program aimed at reducing hospital readmissions, right? So you've already been in the hospital once. They're trying to keep you from getting readmitted, especially for the same ailment, whatever it might be. So how are they going to do that? Well, CVS's Aetna insurance arm will expand a nascent program pairing members in its privately run Medicare plans, Medicare Advantage plans, pairing them with nurses. And the effort, the company says, will reduce hospital readmissions, which are very costly and certainly detrimental to a patient's health. Basically, for patients on Medicare Advantage plans, right, people age 65 and up, the program, and here it says the program might assign an Aetna employed nurse to those people who are released from the hospital or maybe transitioning from hospital into a skilled nursing facility, right? And they have to navigate additional needs. So the services might range from providing coordinated in-home care to ensuring transportation and follow-up appointments. So basically, they're theoretically, if you're released from the hospital and you have an Aetna Medicare Advantage plan, you could very well get assigned an employed nurse that's employed by Aetna to specifically work with you in your case and make sure that you have everything you need. Their goal is to prevent you from going back in the hospital, especially for the same condition they just released you on. Right. So whether it's you're going home and you're recovering, or maybe you're moving to a skilled nursing facility, Aetna employed nurse might get paired with you. It says our goal is to literally have a nurse at the bedside with that member, with that family, beginning to think through what their care journey might look like. There we go. And this move here, a little more of why they're doing this. CVS's move comes after the Center for Medicare and Medicaid Services in July that finalized a rule including Medicare Advantage members in calculations for readmission penalties applied to hospitals. The American Hospital Association has protested, said it would wrongly penalize hospital for negative outcomes associated with coverage delays and denials. Right, so they are putting this together, and they're going. It says here that they will implement the program in 10 hospitals by the end of the year. Some of those hospitals include Advent Health in Shawnee Mission, or Advent Health Shawnee Mission in Kansas City, Houston Methodist in Texas, Wake Med Health in Raleigh, as an example. So when those folks get discharged, if they have an Aetna MA plan, they very well might get assigned a nurse to help coordinate that. Fairly simple. All right, let's jump into some meat and potatoes. This time of year, like I know we're all gearing up for AEP, but every year, this time of year, there's something we're all waiting for and wanting really badly. And that is the new cost for Medicare. We want to know, like, how bad is it going to get? Is Part B premium going up? Is the Part D penalty amount going up for surcharges, right? Is the Part B deductible going up? Is the Part A deductible going up, right? And those are the primary things that change every year. And they still haven't announced it yet. We still don't know. And it's not uncommon that we don't get these numbers until around October. So I expect them basically just about any day to roll out. I think last year they didn't roll out until like mid-October, if I remember right. I might be off on that. But hey, what are we going to have to pay? So we're going to give you some projections. This is out of Kiplinger. And this article here talks about projections for next year, for 2026. I'm going to hit you with another article after this one that projects the cost of Medicare all the way to 2034, if I remember correctly. And it shouldn't be any surprise to you that it's going up. I think you might be surprised on how much it might be going up. But the cost of Medicare is going up for sure. And cost of healthcare in general, like we know that. So projections for Medicare's 2026 income-related monthly adjustment amounts are out. I'm not going to read this whole article because I know that none of us are really concerned about that. What we are concerned about is these actual numbers that are down here. And here they are. This is your projected Part B premium and IRMA brackets surcharges. And again, this is projected. These are just people now analyzing where we're at, what's going on, and what are the possible costs that we're looking at for next year. Well, number one, we're looking at a Part B premium that's going to jump to $206.50. That's one of the biggest jumps we've ever seen, a little over 11%. We get a comment in the chat from Jeremy Ryan, says Blue Cross says Part B deductible going up to $288. Very possible. I mean, it's $257. $288 wouldn't be terrible, but yeah, it's probably about right. You know, and every year there's always some article, Kiplinger or somebody puts out like, hey, what is the projected Part B premium, projected Part A deductible, all that. And the projections are usually pretty spot on, man. It's very rare, and if they miss, they usually don't miss by much. So our projection is about 11.6% increase to $206.50 for Part B. And they are now going to change this number, it looks like, from 108 right now, if I remember correctly. So they're going to bump it up to 109 and 218 if you're joint. But look at some of these surcharges. The current Part B IRMA surcharge at base level $74, right? So if you make more than $109,000, but you don't make $137,000, you would pay $74 more on top of $185 for your Part B. They're projecting that to jump to an $82.60 surcharge. If you make more than $137 but not $171, they're projecting your surcharge to basically double your Part B premium. So they're going to, if it's already going to be $206.50, now they're saying we're going to add another $206.50 to that number to make your Part B premium $413. Next step would be $536 Part B premium. That's with a $330 surcharge. If you make more than $205,000, you were looking at a $454 surcharge to now bump your Part B premium up to $660. And if you make more than $500,000, it's going to cap you out at $702.10 with a $495.60 Part B or IRMA surcharge for Part B. So again, these are projections. These aren't facts. This is probably where we're headed, but until Medicare releases the hard numbers, we won't know for sure. So don't share these with your beneficiaries and saying this is what the new numbers are. You can certainly say this is a projection. Just make sure you're saying that. Right? And I would even encourage you, just talk to your clients and be like, look, I don't know what the number is yet. I'm probably going to learn here pretty much any day what the exact number is, but I just want to prepare you, Betty. The cost of Medicare is going up, and it may go up as much as to $206.50 just for your Part B premium. Here's your Part D IRMA for 2026. So you're looking at $1,450 at the first level as a surcharge. And that's, again, that's projection. Right now they're getting surcharge $1,370. $1,450 is not a massive jump. Second level's at $3,530. So these aren't as astronomical or as large, but still some significant increases as well. So if you're, one of those folks out there on Medicare and you're making more than $500K, I've got a couple of them in my book. Your premium for your Part D is going to be $91 on top of your premium, and your Part B could be another $495.60 on top of your $185, making it $702. So pricey stuff. And I don't think it's any shock. Like the rest of this article is basically is kind of some generic info. Like that is the crux of it right there. But let's dive into some future cost. So like I said, that first article that I just gave you was projections for next year. And those projections that I just showed you, the 206.50, et cetera, those have been consistent across every article I've read. Haven't seen anybody that's saying anything different, which leads me to believe that we're probably going to end up on that number or very, very close to it. But Kiplinger put out this article looking at what the Medicare costs are going to be over the next decade. Buckle your seatbelts. So similar to Social Security, Medicare is facing funding issues. You may have heard that the hospital insurance fund for Medicare Part A is expected to fully pay scheduled benefits only until 2033, 3 years sooner than last year's projection. However, it's not as if the cost of Medicare will stay steady and suddenly increase in 2033. Instead, Medicare beneficiaries have a more immediate problem in the form of rising premiums and surcharges starting in 2026 over the next decade. That's this paragraph right here. Moving along, it says that the 2025 Medicare Trustee Report projects a steady increase in Medicare Part B premiums and IRMA surcharges over the next 9 years. So again, this is the trustees report that they're quoting. This isn't just some other financial analysts out there or somebody trying to come up with this stuff. They're pulling this straight from the trustee report. The projections are based on expected rises in healthcare costs, particularly for outpatient hospital services and physician-administered drugs. It's crucial for retirees and those approaching retirement to understand these projections for proper financial planning. The projections in the 2025 report show a significant increase compared to last year's report. The largest year-over-year jump is expected between 2025 and 2026, with a projected increase of $21.50, setting the 2026 Part B premium at $206.50, which we just talked about. The 2024 report projected a 1% increase, with premiums only going to $186.90. But the 2025 report tells a wholly different story. The report estimates that the standard monthly premium for Part B will potentially reach $350 by 2034. If the estimates are accurate, the Part B premium is expected to rise 188% by 2034. And yes, Mike, I will definitely make sure that these two articles are in the group. So right here, they're giving you your projected monthly premium and your projected deductible. There's that 288 number that Jeremy was just quoting for the Part B deductible for 2026. But this is the projection for the next 9 years. $206.50 for next year, $218.60 for 27, on until we get to 2034, and a possible $347.50. This is just your base Part B premium. This doesn't even include IRMA surcharges yet. We're just looking at the Part B premium projection for the next 9 years. Part B deductible, we're projected at $288 next year, all the way to 2034. We're looking at $486. The deductible is like the least of my concerns. As a matter of fact, which they can't do because they need the money, so they have to jack up the premium, because they need the money to cover the money, the lack of money in the trust fund. So they have to increase the premium to help cover the cost of Medicare itself. Because if you've ever looked at a spending chart on Medicare, it's grotesque. It'll make you want to vomit. And when I originally did a big study from 2010 to 2020 to 2030, sorry. I did a 10-year study, like what's it going to look like from 2020 to 2030. And Medicare spending was projected to hit $1 trillion in 2030. And if you pay attention to this show at all, I've already told you, we already crossed $1 trillion in Medicare spending last year in 2024. 1 trillion, that's a lot of money. So they have to raise the premiums to cover those costs, right? That's the number that hurts. The deductible, not as big a deal to me, right? Especially when you understand that the Part B deductible is usually just paid in piecemeal. It certainly does increase their out-of-pocket, but it's not nearly as painful, right, as the premium. I could probably guarantee you just about every beneficiary you talk to would rather have a lower Part B premium and a higher deductible, but that doesn't help. That doesn't help Medicare's situation as much. They'll get more dent out of increasing the premium to cover those lack of funds. Let's look at the projected IRMA surcharges. The IRMA is a monthly surcharge is added to the standard Part B premium. The SSA uses the most recent complex federal tax return data to assess your liability for the IRMA. For 2026, SSA will look at 2024 tax returns. I'm sure most of you guys know that, but just a reminder, right? Whatever you pay for Medicare in 2026 is based off of your 2024 income tax return, right? And as your changes, you can certainly appeal and let them know, hey, my income ain't what it used to be, right? But essentially, those who pay the IRMA are paying a greater share of their actual Medicare Part B and Part D premiums. As it stands, the government pays a substantial portion, about 75% of the Part B premium for most beneficiaries who pay on average the remaining 25%. For 2024, premiums from Part B and D covered 23% of Medicare's cost, according to the trustee report. So I'm going to go ahead and jump to the chart here for you guys. But these are the projected IRMA surcharges between 2026 all the way to 2034, right? So if we're looking at tier one, this is the people that currently are making more than 108. Next year, they're projecting it to go to people that make more than 109,000, right? They're projecting an IRMA surcharge of 82.60. If we fast forward that to 2030, we're projecting 105.80 for that tier one. And by the time we get to 2034, they're expecting a $139 surcharge. So to help you out a little bit, if we backtrack and we say, hey, I'm in tier one, right? I'm in tier one. So I'm at 347.50 as my projected Part B premium in 2034. But I'm in tier one of IRMA. And now I have to add $139 to that. So that's what, 500 and almost 500 bucks, about 480 something, right? And it just goes on and on. Look at the top tier surcharge. They got them all mislabeled tier one for some reason. That should be a different tier. But anyway, you can certainly see this. If you make the most money, you're looking at a $782 surcharge on top of the 347 projection for what your Medicare Part B might look like in 2034. Right? So if you are a maximum earner at over 500,000, and they may very well change those numbers again, then you are looking at paying over $1,000, closer to about $1,150 plus or minus for just your Part B premiums come 2034, 9 years down the road. I mean, I'm thinking I'm 50, right? So in 9 years, I'm going to be basically 60, still not Medicare age yet. Medicare going to be expensive for me by the time I get there, ain't it? Other factors that contribute to the surcharges, as I explained above, the IRMA surcharge shifts responsibility for a greater portion of Part B premiums from the Medicare Trust Fund directly to high earners. However, politics also plays a role in determining how many people pay the IRMA by adjusting thresholds, freezing inflation adjustments, changing methodologies. So when they're talking about methodologies, in a lot of cases, they are talking about the income brackets and how they might alter those a little bit. Not too many projections on what the income brackets might change to, but these are definitely some of the costs that are projecting, right? So, I mean, if I'm an agent in this space and I'm seeing this type of data, how do I convey that to my client? How do I protect my client? Am I just trying to protect my client for this year? Or am I teaching and educating my client to help them understand that, hey, for the next 10 years, your costs are going to go up every single year, period. Like, you need to start planning and you need to start thinking about not just what type of coverage you're going to need today, but what it's going to kind of look like in the future for you. I mean, outside of just your healthcare plan, obviously they can change their healthcare plans and their Medicare plans on an annual basis for the most part. But what are some of the other things that they need to prepare themselves for? Right? For those that are high income earners, they probably should be talking to them about annuities and savings, ways to protect themselves there. If they're lower income earners, you need to talk to them about the right type of insurance that's going to stay with them to help them when they get to some of those harder times and offset that for them. So I want to move along and I want to dive in a little bit I want to talk a little bit about skilled nursing stuff. because this is from Yahoo Finance, and it was apparently a bit of a study done by Research and Markets. But they did an analysis of market trends for skilled nursing from 2025 to 2033, right? And if you're an agent out there, just to remind you, Medicare gives your clients 20 free days of skilled nursing when they come out of a 3-day hospital stay. The next 80 days, if they stay in there, have a copayment. If I remember correctly, what is it, $214 now? Don't quote me on that. I might be a couple of dollars off. And then after those 100 days, like, you got to pay it all yourself. So here we go. Right here. The U.S. skilled nursing facilities market size was estimated at $199.72 billion in 2024 and is expected to reach $290 billion by 2033. Growing at a compound CAGR, compound annual growth rate. It is growing at a compound annual growth rate of 4.39%. Don't you wish you could get a compound annual growth rate on your money at 4.39? Wouldn't be bad. But skilled nursing is going to. Why? Why do you think that is? Well, it's just demand. That's all it is. Like, we have an exploding aging population. If you've ever heard me talk about the health trends that are happening with our senior group, you know that they're getting sicker, right? Every generation that ages into Medicare currently is a little sicker than the last generation in some effect, right? So, and I don't have all this data in front of me, but I'll give you some stuff off the top of my head that I remember from that presentation. As an example, hypertension. In 2020, hypertension was around 50% of Medicare beneficiaries. But by the time you get to 2030, about 79% of your Medicare beneficiaries will be diagnosed with hypertension. Like, that stat alone makes me hypertensive, right? 8 out of every 10 of your Medicare beneficiaries that you talk to by the time you get to 2030 are going to be diagnosed with hypertension, high blood pressure problems. Now, that in and of itself, not surprising. We live in a high stress world, right? We're overloaded with information, which increases anxiety. There's problems. They're worried about outliving their money. Like, it doesn't. I'm already hypertensive. Like, I can't imagine what it's going to look like when in 2030. So that's one stat. Another stat, and this is the one that's super alarming to me when I think about this, because it's a comorbid that runs along with hypertension. By the time you get to 2030, 48% of all Medicare beneficiaries will be diabetic. So, looking at that data closer, those two statistics, and I don't have it right in front of me. This is going by memory, right? But I've looked all this stuff up. I want to say that might have been from the hospital administration. I'm not sure exactly where I got that. If you need my sources, I'll pull them up for you later. But if 79%, by the time you get to 2030, if 79% of your beneficiaries are hypertensive and 50% of them are diabetic, that's one of the hottest comorbids to get declined for Medicare supplement insurance, for example, right? So if you're an agent out there that sells Medicare supplements, you know that anytime you have diabetes with heart complications, it's going to be a problem. And you're going to have to shuck and jive a little bit to try to find coverage for them in the right place, unless you're getting them through open enrollment or something, right? So when you have an aging population that is getting sicker, costs are going up. And with those costs going up, more and more people are getting moved into SNFs from time to time, whether it be recovery care or living there, right? So right here, there is a high demand. So this giant explosion of SNF is just due to demand, right? It's not rocket science. There is a high demand for skilled nursing facilities in the U.S., as they can provide quality of care at a much lower cost than hospitals. Quality is pretty relative there if you've ever been in an SNF. Some are certainly very nice, some not so much. Rising geriatric population and high prevalence of several chronic diseases are boosting the overall acceptance of SNFs in the U.S., driving the market growth. As per data published by the Population Reference Bureau, the number of people in the U.S. age 65 and above is estimated to reach 52 million by 2050 from 58 million in 2022. Maine, 44.8%, accounts for the largest population or proportion of the population age 65 and above. Utah, 31% accounts for the lowest proportion. Interesting. The risk, and here it's exactly what I just said. Here it is. The risk of diabetes and cardiovascular diseases increases with age, which results in a higher incidence of these diseases in adults age 60 and older. SNFs offer on-site dialysis, ventilator care, orthopedic rehabilitation of the geriatric population, among others. Right? These factors are expected to propel the market. As per the report from the American Diabetes Association, diabetes is a widespread health issue among the elderly population. More than 25% of individuals age 65 and older are currently, and about 50% are having pre-diabetes. The prevalence of chronic disease is increasing at a significant rate. I just mentioned that. Along with general age-related disabilities, the elderly suffer from chronic diseases such as cancer, heart problems, diabetes, cerebral palsy, Parkinson's disease, multiple sclerosis, dementia, Alzheimer's, and mental stress. The rising prevalence of Alzheimer's disease, especially dementia, is a key factor boosting SNF market in the U.S. According to the Alzheimer's Dement Report, in 2024, around 6.9 million Americans aged 65 and above were affected by Alzheimer's. That figure is projected to rise to 13.8 million by the end of 2060, unless there are significant advancements in medical science to prevent or treat Alzheimer's. Medicare and Medicaid continue to play a critical role in supporting the U.S. SNF market, as these programs remain the largest payers for post-acute and long-term care services. Recent updates from the Center for Medicare and Medicaid Services highlight meaningful reimbursement growth, which directly supports SNF operations. For instance, the fiscal year 2024 unadjusted federal per diem rates increased across categories, yada, yada. So I bring that up also, and one of the reasons this is at the top of the newsfeed today, or one of them, is because Medicare recently enhanced, right? Actually, it says it right here. The U.S. skilled nursing facilities market offers significant opportunities due to the rising geriatric population, increased prevalence of chronic disease, and then at the bottom here, it says enhanced Medicare and Medicaid reimbursement support growth, right? They've recently enhanced those reimbursements to those facilities. I actually think last week or the week before, I pulled up an article that talked about that from the American Hospital Association and how they are now increasing some of the reimbursements to these SNFs. So good for them. Like, they need to get more money because they need to be able to take care of us and our clients as we're getting older. But yeah, I mean, it's getting more expensive. Like, if you haven't understood the trend of what I've been talking about the last 15 minutes, it's getting more expensive and they're getting sicker, which is a compounding problem, right? That perpetually feeds itself. The sicker we get, the more expensive it gets. The more expensive it gets, the harder it is. So in just a couple of stats for you. The average length of stay in a skilled nursing facility or nursing home varies significantly, with the reported average of about 485 days. And this is based on the National Institute of Health that I'm looking at. I'm not sharing this. These are just some data that I have here that I'm looking at. So the average length of stay in a nursing home is about 485 days, 1.3 years. And again, that's based on, that's a 2019 study, it says, from the National Institute of Health. A large portion of residents, about 43%, stay less than 100 days, needing care for short-term rehab, while about half stay longer for chronic illness, end-of-life care, which can be months or years. Now, I've seen this data before and I can't find it today, and I've been looking for it, but I've heard that the average Medicare beneficiary uses 37 days of their skilled nursing coverage, which means they wipe out the 20 free ones and they use about an extra 17 with co-payments. I can't find that data now, but I've seen that before. I promise you, don't know how factual that is. But again, this right here from National Institute of Health is telling me 485 days is the average length of stay. Now, that's across all people, not just Medicare beneficiaries. That is just general data across all people that end up in skilled nursing, right? The reason I bring that up is because you as an agent need to be prepared to talk about that. As long as you're in a state not like California or New York, where they outlaw products that you can use to solve those problems. Because if you're in California and you get sick like that, they want you to just go to Medi-Cal and let them pick up the tab and make you destitute so they can, I guess, run your money down and steal your property. I don't know what's going on in California and why they've outlawed all supplemental health products. It's asinine. But if I'm an agent out there and I understand that, hey, number one, the cost of everything is going up, and the odds that you're going to spend time in skilled nursing facility is compounding every year because of the growing rate of chronic disease. And if all those Medicare costs are going up, then we know that the cost in skilled nursing is going to go up too. But if I'm doing that, then I am going to look to fix that for my clients as best I can. And you guys do what you want, but this is a product that we pitch. It's UNL's home healthcare product. It's available in almost all states. Again, California, no. New York, no. Florida, off the top of my head, I'm not sure if it is in Florida. I'd have to go double check my state availability. But dude, this product, I'm telling you right now, is outstanding, and it's highly overlooked, in my opinion. It is not pricey, but what it will give them is 360 days in skilled nursing, short-term care. It's not long-term care. It acts like long-term care, but only for 1 year, 360 days. The reason I bring that up, if I can give them 360 days here, and Medicare's already given them 100 days, then based on the average, if the average is 485 days, then I'm right there. And for my clients that can't afford long-term care, or they can't get underwritten for long-term care because the underwriting on long-term care is way harder than this product, this is a great product to fit in for your clients. What it's going to offer you basically is 3 benefit amounts. They're going to give you a plan A, a plan B, and a plan C. Plan A is $150 a day for every day you spend in skilled nursing. Plan B is $300 a day for every day you spend in skilled nursing. Plan C is $450 a day for every day you spend in skilled nursing. These little charts on the right will tell you how much you can get under plan A, B, or C based on specific items. So you can, for example, on plan C, you can get $450 a day, but allotted, where can it go? Well, only 200 of that can go to skilled nursing and general care, right? 200 of it could go to physical therapy. So depending on the different items that you're getting done to you, they'll disperse that money through there. It also includes a prescription drug benefit. And Kim Favell said, yeah, no in Florida. I didn't think it was in Florida. I couldn't remember off the top of my brain. They include a prescription drug benefit to help offset the cost of this. For every generic drug that your client refills, they will pay them $10. For every brand name drug that your client refills, they'll pay them $25. Even if they're getting that drug for free through their drug plan, right? If they're on whatever drug plan they have and their generics are all $0, doesn't matter. All they got to do is go to the pharmacy, get their scripts refilled, get a receipt, or even easier, ask the pharmacist, hey, can I get a printout of all my drugs? They take that sheet, write their policy number on it with their name, fold it up, mail it in, check comes back. Now, the maximum check will depend on the plan they choose. If they choose plan A, they get $300 a year, $600 plan B, $900 plan C. But I can tell you, and the one we sell the most, because that's the way they have this teed up for you, the good, better, best, We sell a lot of Plan B, the middle of the road, which is $300 a day. That should be plenty, truthfully. I feel like 450 is overselling it a little bit, and 150 is not quite covering the copayment for those second 80 days after they expire the first 20, right? But Plan B, that's right in the cut, I feel like. It's about $50. Plan B for the average 65 to 68-year-old is about $50 a month. So at $50 a month, all they got to do is be taking 2 brand name drugs or 5 generics, and I can get all their premium reimbursed back to them. They get a free home health care product or a free short-term care product that gives them the opportunity to go to home and have the service done at home. Same thing, right? So this is in the event someone can't perform 2 of their 6 ADLs, this policy triggers, starts to pay out and run. It also includes, number one, it's got a restoration of benefits if you have 180 days in between stays, but also it gives you a $3,500 caregiver lump sum payout. So if you have a family member that is going to help you, or if you're going to hire a caregiver that is going to help you, it'll give you another $3,500 to pay them to take care of you. Mike, this is United National Life. Pretty much one of my favorite products. They've also got one of the smoking hot hospital indemnity plans out there, et cetera, et cetera. But this is a product I think agents are absolutely missing the boat on. There are other short-term. This isn't the only one. Aetna's got a short-term care product. I don't think it really holds water to this one. GTL's got one. It's basically almost the exact same product because GTL and United National Life are sister companies. But it's a low-cost, kick-ass product that you should be talking to your clients about. And if it were me, if I were the agent, I'll tell you exactly how I would do it. I would go back. I would share this article. Like I would make a video on Facebook or wherever you want to put it. You could make a video, put it into an email blog and send it out. I don't care. I would make a video talking about this article. I would get a little extra data that I talked about in regards to the prevalence of chronic disease and how it's going. Boom. And then I would talk about this product and how I can help them. You don't need any CMS approval to talk about this type of stuff because it ain't a Medicare Advantage plan, right? I can come out and talk about this all day long anytime I want. The only thing I can't do is just openly quote rates on it. But I could absolutely talk about, number one, the need for this product, and number two, the product itself, right? Fairly simple. So that is the show for the day. If you guys are interested in United National Life or this home healthcare product, feel free to give me a holler. I'd be happy to get you some details on it. But you know, my message mostly was just like, make sure number one, that you're informing yourself. Like if you're a professional in this industry and you're not taking some time to read information about regulatory changes, about health trends, right, and what the future is looking like, then you're short-sighting your ability to advise your clients. And then when you find those trends and you discover these things that you're educating yourself on, you need to find products that can solve those trends and the problems they create. And then you need to explain that to your clients. It's pretty simple. So that's the show. Thanks for tuning in. We'll see you guys next week for Tuesday training. Have a great, great week. And let's get ready for AEP, man.